I'm going to bring to the floor now for the Chiesi Mini-symposium. So we're going to have Thomas Gutstahl, Pat Gorman, and Stefano Pavanello on the panel, and I'll give the floor to Marisa Minetti to introduce the panel discussion.
Okay, so hello everybody, my name is Marisa Minetti and I head the patient engagement activities in our respiratory programs in our global clinical development at Chiesi, and I would like to warmly welcome you to this Chiesi Mini-symposium on palliative care. So often when people hear the word palliative care, they think of the end of the journey. But we are here today because palliative care isn't about the end of life. It's about the quality of life starting from the very moment of diagnosis. It's about ensuring that no patient walks this path in isolation. So to explore how we can bridge the gap between clinical treatment and the true holistic support, I am honoured to introduce our three expert perspectives. So we start with the clinical perspective and Dr. Thomas Gutstahl, a leading pulmonologist from the Erasmus Medical Centre. Thomas is a champion for the clinical empathy, working to ensure that medical research and symptom management go hand in hand. Next, we have the nursing perspective with Pat Gorman, a specialist ILD nurse from Belfast. Pat is a master in bridging the gap between hospital care and the home, ensuring dignity is woven into every stage of the journey, including also support to the family and caregivers. And last but not least, we have the patient perspective. We are joined by Stefano Pavanello, a dedicated patient advocate and board member of the EU PFF. And as a lung transplant recipient and an EU party expert, Stefano brings the vital voice to this stage about the lived experience, reminding us why the patient must remain the central focus of every healthcare decision. So now I will hand the word to Dr. Thomas Gutstahl, who will give us a brief presentation, and then we will follow that with a panel discussion. Thank you.
Great, thank you so much for this warm welcome and this opportunity to talk about a very, very important topic, which is palliative care. And I'm very honored to give this talk or this session together with my co-participants, of course. And today I would like to talk with you about palliative care. But palliative care often has a ring to it which doesn't resonate quite well with patients or caregivers. So today I would like to give a talk and to really open this topic. So first, why does this topic matter? We know that in patients or people with palliative or pulmonary fibrosis, a lot of debilitating symptoms can take place. So we know that progressive dyspnea can take place or severe cough, very debilitating symptoms. And the biggest problem that we have is that palliative care is only frequently introduced only near the end of the life. So I see it also in the Netherlands, but probably also in other centers, that the talks about palliative care are often only introduced quite late, or too late maybe even, because communication and coordination is only often fragmented between all the specialized caregivers. And I think the goal should be, and that's why it's so nice to talk about it today, should be that we have early integration of supportive care. We know that it's important, it's highlighted in every guideline, which we're going to talk about, but we should work on early integration. And also close collaboration between all caregivers. And in the Netherlands, we have a new program set up, which I will shortly talk about, which might be a conversation starter in this. So, as I think very well mentioned, palliative care is not the same as end-of-life care. Often these two are very intertwined terms, but I think we should really pull them apart, because palliative care, or quality of life care, as we call it in our center, is very much different from only end-of-life care. We know that it should be holistic, multidisciplinary, and patient-centered. And it should be really focusing on quality of life, because the quality of life journey starts already at the diagnosis conversation, and not only at the end. And we know that it should address these different domains, so not only physical domains with medication, but also psychological, social, and spiritual needs. And we know that it's most effective when tailored to patient values, cultural context, communication preferences. We know that patients have different perspectives on this. And especially we should talk about the wishes that people may have, because they can be very different per person. We also know that it can be delivered alongside this disease-directed therapy. We've talked about drugs before, of course, which are very important, but I think the holistic or the multidisciplinary care for pulmonary fibrosis patients really vastly extends beyond medication and should be addressed early on. So this is a large piece of text, but just to emphasize what I think should narrow down the palliative care that we should work on. And especially, and that's why the part I like the most, is that we should also take into account cultural differences, because there's not one size fits all for palliative care in these patients. If you look at quality of life, it can be very different per person. So I think the number one priority for any caregiver in this disease should be to really assess the specific patient or person-centered needs. And this is how you can make decisions together. So why is it so important in pulmonary fibrosis? As you all know, this disease can bring a very high symptom burden, often besides the medication. And we know that it can lead to progressive functional decline, also affecting daily activities. And I think the narrower these boundaries become, so the smaller your area of span becomes, the more unpredictable your disease trajectory can become. There's also a risk of acute exacerbations, which were mentioned before, also a big detrimental problem. And especially we know the psychological impact, not only on patients, but only on caregivers. Pat and I were talking this morning about our experience in treating these patients, but also the psychological burden of seeing the loss of quality of life that these patients have. Also affects us as caregivers, because we're also humans and we really are connected to our patients. So the project goes both ways. What we need is timely communication of an advanced care planning. As I've mentioned before, it shouldn't be introduced all the way at the end of the disease. It should really start at the start of the disease. So the minute you talk about the disease and all the detrimental effects that it can have, also the conversation, in my opinion, or in our opinion, should be opened on what quality of life care should look like. And all these different domains should be addressed. So the key message should be the palliative care could really help manage symptoms and support patients also. So what are barriers currently to adequate palliative care in pulmonary fibrosis? We know that there are a lot of misconceptions about palliative care. Often the word on its own already has a very negative surrounding around it. It's often even a taboo. People don't want to talk about it. There are a lot of emotions around it, involving it. And often it's perceived only as end-of-life care. So the minute you mention the palliative word, people are often in distress. They think it's the end of the life. And we know that it's important because there's an unpredictable disease trajectory. So while somebody can be quite well in the beginning of the disease, it can be very unpredictable and should be, I would say, even discussed right away. The focus, of course, there's a big focus on disease-modifying therapies, which is good because drugs can really help. But I think the holistic picture is something that we need to see and not only have a hyper-focus on medication. Often, and I'll come back to this, we have fragmented care organization. So we have a lot of caregivers involved, of course, in pulmonary fibrosis. Not only pulmonologists, nurses, but also GPs, specialized nurses at home, friends, loved ones, families, everybody is involved. But we need to communicate with each other. And we have limited routine screening for supportive care needs. Often there's little time to talk to your patients. It has to be quick. We have limited time. So these are all barriers that we should talk about. And that's why I think it's a nice session today to open up the floor to these experiences. So what are the numbers about palliative care? We know that only 20 to 30% of patients are referred to a specialist in palliative care, which is far, far too low. And again, the many referrals only occur in the last months of life. And if you take a look at population studies, we know that 30% was even referred within the last month of life, which is far, far too late. And 70% even in the last 6 months, also too late. So again, really the focus on the end of life, while it should be at the start of the disease. So the implications are that it's now more reactive instead of proactive. We should really move to the proactive field. And in the end, there's only limited time for advanced care planning, whilst you want to take all the time that you can to really get this going. And you have reduced opportunity for caregiver support, because often it's quite rushed. So what do current guidelines recommend? We have various guidelines, and they both really recommend that you have comprehensive IPF management. So not only drug therapies, but the holistic care way. And also in the ERS clinical practice guidelines of 2023, it's mentioned that it should be needs-based, like we've talked about before. So it's not a one-size-fits-all. It's not the whole package for one patient. It should be really vigorously assessed. And that's something that I think we should really work on. So how can we bridge the gap between these guidelines and the practice? So the key barriers that we've talked about before, I think leads to a key challenge, in our opinion. And that's how can we translate these guideline recommendations into a structured, integrated care pathway for patients with pulmonary fibrosis. Because the theory is nice, but as you see in the numbers, we still need to gain a lot. So lastly, I want to give you a short overview of projects that I've been working on in the Netherlands. And I'm very proud of this actually, because it's the ZOPAL project. So we've been working on early integration of supportive and palliative care from the moment of diagnosis. And this is something I cannot emphasize enough. And our core principles were the early identification of supportive care needs, but again, also the structured communication between caregivers. Because we saw in the Netherlands that there are a lot of caregivers, they're very passionate about giving the care, but they're quite fragmented. They don't communicate really well with each other. For the patients, it's unknown who they can knock, whose the door can knock at. So we should really know where can they go. So we've made a care network of all the caregivers that you see here below. And our vision would be that it would be running in parallel with a disease-directed therapy. So of course you can get your drug therapies and your medication, but alongside, from the beginning, you should have a vigorous supportive care pathway. And this is something that we also see in the guidelines. So if you look over time at the bar on the top, you know that on the left you have the diagnosis, but already when the treatment considerations start and the monitoring, you should really assess also the care possibilities. And so this is in Dutch, so hard to read and to understand, of course, but just to show you that what our care pathway looks like, and it's available on request, of course, also in English. But it's just to show you that we've made a care pathway from the dot all the way to the left, which is the diagnosis, all the way to the very end. We look at the journey from every part of the view. So starting already from the start of the journey, we already plan advanced care planning conversations with patients with specialized nurses, if they want to, of course. And we really have a vigorous evaluation process for this, with the nurse specialist as the monitoring agent from the middle. And again, the most important part is the transmural or the extramural collaboration that we have between the GP, the pulmonologist, the patient, the nurse, all the collaborators. And what we want to achieve is that we have an early introduction. We want to have regular assessment, of course, multidisciplinary coordination, but especially the transmural, so that bring all the colleagues together to get the right care at the right place at the right time. And we are now currently evaluating this. We're doing a pilot with 10 patients already, and it's going quite well. The patients are very happy, and we as caregivers also. But there will be more to follow on this. So the expected benefits would be, of course, early symptom management, but especially the reduced frame care, the communication. And I think that's something we can really work on today, and that's why I'm very excited to be together with the panel, which was introduced very nicely. So I'll move backwards, and I would say I would love to open the discussion, because as you see from the numbers, we have a lot to gain, and you might have own experiences or questions or feedback or advice. So we'd love to hear your thoughts on this. And we've composed a few key questions, but feel free to let's open it up. So I'll move backwards.
So thank you, Thomas. So I think we can start with the first question. So what are the most important unmet needs for patients with pulmonary fibrosis?
Maybe I can shortly start. So I think for me, as a pulmonologist, I would say the most unmet need for the patients that we see is the timely start of the discussion. So often I see in patients and also with my colleagues that it's often introduced far too late. And I think it should be already introduced, at least a conversation at the very start, because for all the different caregivers, you would need to have time enough to really address their needs. So I would say the time issue for me is an important part. Oh, I see we have a question from Professor Wuits in the back.
Sorry, thank you for your very nice presentation. Timing-wise, it's something that we really struggle with as healthcare providers, to be honest. I know that your colleague Marlies is very keen on having palliative care introduced the very first day at a diagnosis. We really struggle with that, to be honest, because many patients come in and they fear they might have cancer. So then for them it's a relief when they have the diagnosis pulmonary fibrosis, and it takes time for them to come up to terms with the new diagnosis, the new disease. So myself as a healthcare provider, I really struggle with what is the right timing to kick it in. And obviously I date from the medieval ages where we initially did cure, and then when there was no cure anymore, we thought of palliative care. Obviously, that's not the right way to go, but could you help us out from your own experience, from the research you do, how we should tackle this?
Yeah, I think we should all comment on this, but I can start from the pulmonologist point of view. Is that I, at least personally, always start the conversation, of course, explaining the diagnosis and what it means. But also I ask the patients whether they have thought about what the disease can mean for them, if they have any cultural or religious aspects that they want to discuss. And I don't immediately talk about end of life, of course, because it can be a very different trajectory. But I do discuss that, or I mention that this disease can have profound effects on your health and on your loved ones as well, and that if the patients are open for a conversation, that we have specialized nurses. That's why I think we should get Pat also in the conversation, because I think to at least open up the conversation gives the patient the opportunity to talk about it. Although we do have patients also that do not feel the need to talk about it. Also fine, of course, it's always your own decision. But I do notice in my own clinic that there's a lot of conversation that can be started. And especially early on, it really helps because it's a difficult barrier to break. But I think it's really necessary to really get the discussion going. But maybe, Pat, we can hear from you and from Stefano.
Okay. I think the earlier we start the conversation, the better. And I think it's perhaps, gaining the patient's consent. We're going to talk about, supportive care. And I tend to say that, palliative care is another layer of support. And I often say that, when patients present, they present with symptoms, and that's us starting to palliate those symptoms. So I really do think the earlier the better, because the trajectory is so unpredictable. So yeah, I think conversations have to start at the beginning.
From my experience in Italy, I can see that the problem is that the patient doesn't know exactly who is responsible for this kind of therapy, because very often it is not given inside the hospital or the clinic, but it's something which is made by the local health system, and the problem is that they are more concentrated to oncology patients. They still don't have enough experience with the different kind of patients.
Yeah, and I think that's something we can really learn from, because the oncology field has a lot of extensive experience in delivering palliative care. But I think the lessons learned from this field can be really drawn into our own specific field, because, of course, pulmonary fibrosis is very different from the oncology field. But there are a lot of similarities in how we can assess problems in patients, how we can talk about it. And for one, in our center, we call it the quality of life outpatient clinic. And that's, I think, what it should be, because palliative does imply, exactly like Professor Wout said, that if you are not being able to be cured anymore, you transition into palliative care. But of course, I think from the very start on, in every disease, you should really assess and try to improve quality of life. And I think that's something we should not be segregated in, exactly like Pat says. We can learn from each other. But even though pulmonary fibrosis is a specific disease with its specific requirements, for instance, oxygen use is something that's very pulmonary fibrosis specific, and that's in assessing whether you would need to have physiotherapy or other forms of quality of life improvement is something that you really should get some knowledge about. And I think that could be also an unmet need, that we need more knowledgeable professionals. And like Stefano, I think very correctly says, that it should be very crystal clear for the patient for whom they can go to for these kinds of questions. And that's something that we also assessed in the ZOPAL project, so the project in the Netherlands. So first we had a lot of conversations with the patient advocacy groups in the Netherlands. And one of the main points or unmet needs that came across was that for patients it's very difficult to see who they should go to with which question. So if it's a medical question, am I still in the treatment of the pulmonologist, or should I go to my GP? If I have questions about oxygen, who should I go to? And this can create a lot of barriers to even ask questions or to assess the kind of care that we need. And in this project, at least, we have a communication platform between all these different caregivers. So if there's a question from the patient, it can automatically, or we can assess how it can go to the right person to answer the question. And I think the patient, as a patient, you should not be able to look for who the question should go to. You should just be able to ask your question, and then the caregiver team should be really united. But it's also a communication issue, I would say.
If I can add something, is that actually it's more nursing service, but we have seen that it should be a more holistic treatment, and this is not made actually in my experience. So we have also to change the way we do palliative care. The needs are not only to, something that nurses can do, but sometimes you need psychologists, you need other kind of help which is not provided.
Yeah, and I think that really emphasizes to me the tailor-made part of it, so the personalized part, because for every patient it can be different. Some patients have a very large social support group. Some patients are sadly more isolated, and for every patient individually it should be assessed. And I think maybe a solution or a step forward could be that after the diagnosis conversation, so the first conversation that we have, I think we should really have an involved specialized ILD nurse, because it's also often a time issue. As a pulmonologist, we have limited time to talk to our patients, sadly, but if you can get a conversation started with a very specialized ILD nurse, really opening up this conversation, I think the first and most crucial part should be to assess what are the needs, because it's very different per patient. And like you say, Stefano, for the one patient it can be left, for the other patient it can be right. And by assessing this, you can really make it tailor-made, because that's how we can make it also efficient. But Pat, maybe you want to comment on this?
Yeah, I think we had a conversation earlier, Thomas and I, about psychology. And we are fortunate that we have a part-time psychologist. She's respiratory, but is going to devote some of her time to some of our ILD patients, which is amazing. And I just think that, you know, a psychologist should be part of the MDT and would be very useful in taking patients through this journey.
Yeah, so what I'm hearing is that certainly we have to improve collaboration between caregivers and healthcare professionals to make a networking approach more accessible to patients. Is there any other questions?
Yeah, right. It's not a question exactly, but I just wanted to tell you that I was part of this ERS panel about palliative care. That was 2 or 3 years ago, and indeed you mentioned that it was theoretical, and that's true. And I was just worried what was going to happen after this this job that we did, and which took a long time, really. And I am happy to see that now there are practical results on the ground. So I'm very happy to see that, and thank you for that. It would be good if you could share this your experience in doing this with other hospitals across Europe and particularly in the French-speaking part of Belgium, because this is where we are also, and that's extremely interesting. So I'm happy to see that the work that we did has a purpose and serves its purpose. So thank you.
Yeah, thank you so much for this comment. And it really, I can say, it really fueled our efforts as well, because it's such an important topic, of course, and the work that you and your colleagues did also fueled our thoughts of how to really address these problems. So this really, I think, nicely shows how from each shackle, another positive shackle can ascertain. So thank you for this comment.
So mainly just a comment and excuse me, some food for thought. And as a pulmonary provider, certainly speaking about what happens as disease progresses, and an advanced disease can be challenging and difficult. But I've always found it very striking that we can talk about planning for a financial future at the end of our life a whole lot easier than we can talk about planning for our health care at the end of our life. So what I usually do is explain to my patients that, you talk to your financial advisor and we plan for our retirement. We're going to talk about your health care and plan for your future of your health care, just like you would for your finances. I want you to know about all of your resources. That includes symptom support, medication support, and transplant that may go on during the course of your disease. And being able to do that, as you said, as you develop a rapport, you get to know your patient, they get to know you, ends up developing that trust so that you can foster those conversations down the road.
Yeah, great comment and great strategy, I would say, to open the conversation. Yeah, thank you so much. Yeah.
Okay. Yes, I'd just like to bring a testimony of an experience that we've been carrying out in the hospital of Modena in Italy, just trying to train patients and caregivers to support in turn the physicians for the diagnosis and to instruct the patients on their journey throughout the disease. So it is another way, but the end point is the same, to better light the way the physicians can just start telling the people, telling the patients that they are not alone, that it is not the end of life, but they can live together with the disease, looking for opportunities to expanding any moment of their life. And of course, this is a project going on for now a few years, and we need support because the resources in terms of humanity are there. And we are trying to find some collaboration from pharma industry, because with pleasure I've seen during this summit that they are very much involved and committed in giving a holistic contribution to the journey throughout the disease, and not only with therapy and medicines. So this is what I would like to stress. Thank you.
Yeah, thank you for that. That's a great example. And yeah, definitely as a pharma company, we are expanding and we want to look at it from a holistic approach and see what type of support we can also provide. So thank you for that example. Any last question? Maybe because we're running out of time.
Thanks very much for giving me the opportunity. I would just like, from the patient point of view, to remind you that, yes, everything is great, what you've gone through, and I've loved what you're doing. But quite often, and you did mention earlier on, that it's a shock to the patients because they may be coming expecting that it's cancer, and then you're telling that it's pulmonary fibrosis, which is probably a term that they've never heard in their lives. Would you please ensure that you build into whatever you do that the patient does fully understand what you've talked about, because they're going to leave after that consultation with you with more questions that they arrive with. So I think it's very important you give a time for the dust to settle, to allow them to try to find out. But before they get onto Google and get lost in everything that's there, make sure somebody comes and speaks to them very soon, within a week, whether it's telephone or whatever. Any fears that they have, any concerns that they have, any questions that they have are answered.
Thank you very much for this comment. I think it's a very vital and important thing that you say. And I can mention for the program that we have incorporated this because, like you say, probably only 5 to 10% of all the information from the first confirmation or conversation that we have sticks, which is only logical because it's a lot of information. And we plan actually 3 consecutive advanced care planning conversations of over 45 minutes with our ILD specialized nurse. The first one within the first week, like you say, because it's very important for us as well. And then consecutively, because in the first conversation, you, as a patient, you can still be shocked or stunned, your loved ones, your caregivers. So we do it consecutively to not only have a one-time conversation, but to really build up a form of trust and to get the conversation going. Because first and foremost, it should be about the diagnosis, the implications, what it can mean for a patient. But simultaneously, we would like to open up the floor and the discussion with the ILD nurse together to get them into a point of contact for whom they can address their questions. So I thank you for this comment. Yep.
And last question.
Hi. My name's Una McMillan, and I just wanted to say that Pat Gorman is my ILD nurse. When I was diagnosed and brought in to see my consultant, and he told me my diagnosis, I was very confused. I felt quite angry. He then got in touch with Pat, and within 10 minutes, I was brought into Pat's office, and she took time, explained everything to me, and I left feeling much happier. And she is just a marvelous nurse.
A round of applause for that. That's so wonderful to hear, and I think this is 100% the reason why we should do this, because wonderful nurses like Pat really are vital for the treatment of these patients. So.
No, we certainly need a lot more ILD nurses, and speaking to a few of the audience over the weekend, I'm shocked that there are still places in Europe where there's no ILD nurses.
I'd like to add just something for the patient and the people who don't are so lucky to meet someone like Pat. When you go out from the door of a doctor, you always remain with a lot of questions to do, and it's the role of patient association to reply to these questions. So remember that we are here for there.
So thank you so much to our panel members. I think it was a great topic, and I think we can see a lot more in the future. So maybe in the next years we can go deeper into the topic. So we've come to the end of our time, and I hand the word back over to Albert. Thank you so much.